Okay, welcome to the response to your second set of discussion posts. Several of the questions kind of grouped together were related to assessment and etiology. The first question was about MRI. So with the advances in technology, can current MRIs detect some mental disorders in a person? And if so, is this common in today's therapy practices? No and no. MRIs can't be used to diagnose mental disorders in individuals. Now, there are studies that you can read that talk about differences in brain structure. Some, not much that, more so now with functional MRIs, right? You're taking multiple pictures, basically. Looking at differences in brain functioning between individuals with psychological disorders and those without psychological disorders. Right? And they found statistically significant differences where a certain part of the brain is more active in, let's say, for example, people with OCD than people without OCD. Well, and you might say, well, if that's the case, then why don't you use it to diagnose? Well, just because there's a statistically significant difference or finding doesn't mean it's clinically significant or a reliable difference yet. So in those studies that even show statistically significant findings, differences, what you'll usually see is you'll have a group of people with OCD and a group of people without OCD, and they'll give them MRIs of both, and they'll find that there's a bunch of people, more people than you would expect due to random chance, that have OCD that all kind of look alike in a certain way. A certain area of the brain is more active than for other people who don't have OCD. But it's not the case that everybody with OCD shows that same pattern of activation. And it's also not the case that nobody without OCD doesn't show that pattern of activation. Right? So some people without OCD will show the same level of activity in that area of the brain that they think is associated with OCD. And so it's not a clear-cut thing, well, okay, if you see this activity, it's OCD, and if you don't see the activity, it's not. It doesn't work that way. There's enough evidence that they say, okay, well, this area of the brain is probably involved, at least for some people, in the experience of OCD, but there are no findings yet for any disorder that are reliable enough to say, okay, for this, if you have this type of brain structure or this type of brain functioning, we know it's disorder. It's just too complicated. The brain's too complicated for that. Next question. How is significant psychopathology explained from a humanist perspective? This question first was talking about how they could see how the humanist perspective was relevant for kind of everyday problems of living and could explain that, but didn't see how it applied to things like schizophrenia, bipolar disorder, more significant psychopathology. And I think it's a good point. The humanistic perspective has a harder time explaining how more severe pathology develops. That being said, I think kind of hardcore humanist theorists would say that they still could explain it, and that those are just extreme cases of people not getting their basic needs met, and distorting themselves in their reality in order to please others in general. But I think it's a good point that it doesn't. It's not as useful for understanding severe psychopathology as some other theories, other perspectives. Is there a current theory what was wrong with King Charles VI of France? Well, obviously, since he's not around to ask questions, we can't get a definitive diagnosis, but there are kind of psychohistorians that look back and say, okay, given kind of the diagnostic categories we have today, and given the accounts we have of his behavior, what would he most likely have met criteria for? And in 2003, some French researchers, Bourgeoisie, some other people, published a paper reviewing the evidence and gave their opinion, which they basically felt that it was probably a bipolar disorder, bipolar 1 or bipolar 2. And I was able to find that article and read the abstract, but the article itself was in French, which unfortunately couldn't read. I would assume, though, that they would have said bipolar disorder with psychotic features, given that certainly seemed to, from the stories I've read, evidence some psychosis where he was actively hallucinating and had some delusions. But given kind of the chronicity of it, I guess, is what made them think bipolar. Good question. Another one, just really not much of a question. Somebody's kind of wondering something, but I wonder what living in our society would be like if we still use the supernatural as the main explanations for a disorder. I thought that was just an interesting point and kind of something to ponder about. How would things be different? How would the DSM-4 be different? Would we categorize people based on type of supernatural cause, or would there be different types of disorders if we thought of them as being, caused by supernatural forces? This is demonic possession. This is a hex by a witch, whatever you might think. And then also think about how treatment might be different. Probably be the clergy rather than psychologists and counselors who were delivering treatment. Although I wonder if over time, even if that kind of supernatural belief were at the root, if the treatment might not still look the same, because behavior is going to respond to certain things and not others. I don't know. It's an interesting question. The last one about this kind of general topic. What's an example of directly relating the cause of an abnormal behavior to a treatment? Well, easy examples are things like if you have psychosis due to metal toxicity, heavy metal poisoning, chelation therapy. We're taking out the heavy metals would be the treatment. And so you have, okay, if this caused it, here's a clear treatment that you use because that's the cause. More psychological, less biological example would be if you felt that depression was caused by negativistic thinking, pessimistic thinking, kind of just a negative thinking style or pattern. If you believe that was the root cause of symptoms of major depressive disorder, then you would use cognitive therapy, where you would teach people to identify and challenge negative thoughts, and then encourage them to practice new patterns of thinking. Practice thinking positively and see how you feel. And if it's less depressed, then maybe keep thinking about it. That would be another example. Some questions about treatment. One, kind of some historical stuff first. When did they figure out to use electroconvulsive shock therapy for depression? Well, according to Nancy Payne, they've been using shock therapy since the 1600s, but not electroconvulsive shock therapy. Obviously, they didn't have electricity in the 1600s, but they had shock therapy. And shock therapy being just any therapy to deliver a shock, and shock being to induce convulsions for the treatment of mental illness. That's been going on for a long time. But in terms of using electricity, that was in the 30s, late 30s, 1938, and then depression actually was treated with ECD for some people in the late 30s. Although it was controversial at the time, and became more controversial up into the 70s and 80s, to where it almost stopped completely, and then has been somewhat of a resurgence in the past 15, 20 years for those kind of severe, non-tractable or intractable cases. But ECT for depression, no, not at all a new treatment. It's been around for a long time, and it's been controversial for a long time. Might doctors in the future be able to replace defective parts of the brain that cause disorders? Probably not. And I say that because the brain's not like an engine or a computer. We often use metaphors like that. Oh, think of the brain like a computer, because it's helpful in explaining certain processes and related functions of the brain. But the brain's not a computer. It's not an engine. It's organic. And like in an engine, you may have certain parts that aren't necessarily like, where if you take away one part, it doesn't affect another part. It may affect the overall engine being able to work or not, but if you mess with the carburetor, it's not going to affect the fan belt. I don't know if it's true or not. I don't know which one it is. But as an example, some things seem to be less related, whereas in the brain, everything is related. Especially when it comes to kind of higher level processing stuff in terms of thoughts and feelings, things that are related to mental disorders. They seem to involve multiple areas of the brain, not specific parts. There's not, they haven't found, and probably won't find, one area of the brain that is responsible for a disorder. and there was a time whenever scientists thought that the brain was highly specified, where different parts of the brain were responsible for different things. Right? And so you may have heard about Carl Lashley's research looking for the engram, looking for where memories were stored. And he taught these rats to run mazes, and then systematically cut out different parts of the cortex of the brain to figure out, okay, well, once I'll just cut out a little bitty piece. And if I cut a little bitty piece and the rat can no longer run the maze, well, then that's where that memory was stored. And he never found that little piece, because memories are stored in multiple places. You'd have to damage multiple parts of the brain to really take away memory. And it's probably the same way with psychological disorders. You'd have to take away multiple defective parts to change behavior without just kind of old school lobotomizing people, where you just made them brain damaged. So it's not so much parts; it's more pathways. And these pathways, you think about them being kind of neurons, connected neurons chained together, going through multiple parts of the brain. So you could, I guess, kind of theoretically think about replacing a neural pathway, but that would be some incredibly sensitive surgery. And even that might not be effective, because the pathways aren't fully independent, right? One neural pathway that would kind of identify, okay, whenever you're thinking about a certain thing, this series of neurons that goes from point A to point B to point C to point D, they light up. So if we replace that, we can change the way you think or feel about something. Well, there are other pathways that are usually adjacent to that pathway that influence its function, right? You kind of think about it either intersecting it or being adjacent to it, and those other pathways being active or more active or less active will influence the activity of that pathway. So, kind of a long-winded answer to the question. The brain is much too complex to, in my opinion, to ever think that would be realistic. Things are much too interconnected to think about in terms of being able to switch out particular parts. Related to that, a question about Edgar Moniz. Where did he get the idea for lobotomies? Well, Friedrich Goltz lobotomized his dogs in the 1890s, just because, let's see what happens. And he found that they became much more docile, which if you cut out part of your brain, you probably become more docile too. Wouldn't bark as much. And then there was other research that followed that with animals mostly, cutting out different parts of the brains of animals and observing the effect on behavior. And that's where kind of the idea came from. Started with animals and was been applied to other animals, us. Strange. Okay. Next was, might malaria be used to treat Lyme disease? And the question came up because one of the kind of cornerstones to the biological approach, at least that gave it impetus and momentum early on in terms of understanding psychological disorders and the search for a biological cure for psychological disorders, was the finding that late stage syphilis led to the psychosis, and that some people who had malaria stopped showing the psychosis. It cured their syphilis because of the fever associated with malaria killed the organism responsible for the syphilis. Somebody asked, well, might that work for Lyme disease too, given that they're kind of biologically similar organisms, the pathogens? I couldn't find this anywhere, but I consulted a epidemiologist and a physician that I know, and didn't get a straight answer, but they both said, well, it'd have to be a very high fever, not just 101, 102, 103. That's not going to do it. Be well above 105 at the level of fever that would be quite dangerous and might cause brain damage and other harm. So they wouldn't recommend it as a treatment. But yeah, it theoretically could work, but you're probably better off with antibiotics. More questions on treatment. This one's more of an observation. Somebody noted that it seemed that Plato's advice about using reasoning as treatment was a forerunner of cognitive behavioral therapy. And yeah, I think that you hit it right on the nose. Definitely. Plato's work, and then also some of Aristotle's work about associative learning, about how we come to know things by associating one event with another, that very much influenced the behaviorist aspect of CBT, but certainly Plato as well. Another kind of historical thing, Galen talked about behavior change could result from changing the environment. How does this work? Would changing your environment, wouldn't it just involve changing your mind or outlook? And certainly changing your environment can change your behavior. If I plucked you up from where you live today and and sent you to live in the Gaza Strip or the Sunset Strip, those two different places, your behavior would be very different, right? The likelihood of you developing an anxiety disorder very different if you're living in the Gaza Strip or the Sunset Strip. So in terms of exposure to kind of traumatic events, it's kind of an obvious example of how the environment can contribute to psychopathology. So if we put you in an environment that's less traumatic, less stress-inducing, then it makes sense that you would experience a change in behavior as well, a calmer, more relaxed environment that's stimulating in appropriate ways, but not overly stimulating, not causing a lot of negative emotions. And then the second part of this, personally, I don't think necessarily intended it this way, but it kind of caught me when he said, it would involve just changing your mind. I put quotes around the just, because changing your mind and changing your outlook are significant things to really change the way you see the world. Certainly could lead to no longer meeting criteria for a psychological disorder. Could lead to a cure, if you want to use that word, because in some ways that's what some of these disorders involve is seeing the world in a certain way. It seems that is maladaptive, that leads to other problems. So if you can change the way you see the world, change the way you think about things, you may no longer meet criteria for disorders. And remember is also that if you change the way you think about things, if you change your outlook, you're probably changing the way your brain is working and possibly even the structure, the organization of cells in your brain. Because again, there's that mind-body connection. Okay, my humane treatment of patients or inmates a la Poussin and Jean-Baptiste, freeing captives, be effective today? Yes and no. Certainly, treating people humanely will lead them to act more human or humanly themselves. So if we treated patients or inmates, if we're talking about people who are incarcerated, more humanely, they will act less aggressively, more passively, more socially, more civil, use all those words. Kind of humane treatment, moral therapy, would it be a successful standalone treatment for major psychological disorders? No, probably not. People that have schizophrenia, probably not going to get better just by getting humane treatment. It will help. I have no doubt it would help, but it wouldn't lead if they have active hallucinations and illusions, wouldn't probably lead those to go away. It would help them manage their symptoms, and it'd make their life better during when they're not in a psychotic episode. So effective to a degree, but not as a standalone treatment. Why are some mentally ill people homeless rather than institutions? Well, in some ways complex, in some ways simple reasons, economic and political reasons. Mostly economic. It's expensive to put people in institutions. It's cheap to let them be homeless, in the short term anyway. Most homeless people don't have insurance, right? So if the insurance company is not going to pay for their stay in an institution, then the state is, or the federal government, usually the state or some local municipality, and local and state governments they don't have any money. And when they do have money, they don't want to spend it on mental health. And I say that not because they said they don't want to spend it, but because they don't spend it. It's an underfunded priority for most states, especially in Texas. It's drastically underfunded. So if they're not going to pay for people to be institutions, then if they have some profound mental illness and are not able to hold gainful employment, then it's not surprising that some of them will end up as homeless. So what typically happens is, if they're homeless and mentally ill, eventually they'll get in trouble. They'll break some societal rules and get in trouble with the police. Police will take them into custody. They'll determine that they're, they don't need to be in jail. They are mentally ill, and so they'll probably send them to the state hospital. There's one in Austin, Austin State Hospital, and they'll be there for a couple of days, up to maybe 30 days, and they'll get some psychoeducational group classes, do some arts and crafts stuff, get their medications sorted out, and they'll be given prescriptions for medications that psychiatrists there think will help them, and they'll get kind of stabilized, and then they'll get put on a bus to go to Houston or somewhere out of Austin, and told good luck, take care. And then a few months later they'll get in trouble again because they don't have a job, they can't pay for their meds, they can't keep up with the paperwork to get the free meds, and then the cycle repeats and repeats and repeats. But the short answer is, why so many people homeless for the institutions? Money, because we don't want to pay for it as citizens. We don't want to pay more taxes to pay for that. Not a big enough priority for us. Is there any progress on cures for psychological disorders? Well, first off, the word cure, and I have it in quotes here obviously, implies a disease model. It implies that psychological disorders are diseases. And most psychologists don't think of it that way. Most counselors don't think of psychological disorders as diseases, and therefore they don't think about curing them. We think about treating people, right? Not treating disorders, treating people, helping people experience fewer symptoms that cause distress or dysfunction, right? So helping to restore functionality and increase happiness, all these other kind of goals, but not necessarily by curing some disease. So I would say no, there hasn't been progress in curing disorders, in part because it's not necessarily a goal, at least for psychologists and counselors. For psychiatry, that may be how they see it, and I'd say they haven't had much progress in terms of cures. But in terms of treating psychological disorders, in terms of reducing the severity, frequency, duration of symptoms, in terms of increasing quality of life, yeah, we've had tremendous progress in the past 60 years. With anxiety disorders, we do a really good job of treating those, especially with therapy. Some medication at the front end, but in therapy, people long-term do much better. We're pretty good at that, including PTSD, and lots of new research is going to come out in the PTSD area, obviously because of the increased cases in the military. We're getting pretty good at treating that whenever we can, whenever people are motivated for treatment. Depression as well. Not as good, I don't think, as anxiety disorder, but pretty good at treating depression. Bipolar disorder, we're good at managing that. I wouldn't say treating it, but we're pretty good at helping people live normal, fulfilling lives. But with that, it's more of an ongoing treatment thing. Schizophrenia, less progress. It's I think that's still one of the bigger mysteries in our field, how to treat psychotic disorders effectively. That being said, there are some individuals that certain medications and then supportive therapy work wonders, and they're able to be fully productive members of society. But others not so much. Some people, there are certain medications that really work really well for them, but then they have these horrendous side effects that they can't stand to stay on the meds and then get off them. So in some areas, yeah, great progress. In other areas, less. But we'll probably always see it as a work in progress. Partly because, especially if you don't think about these as being diseases, right? But as kind of these organic, biologically, socially, culturally influenced things, they're going to change. Like, so depression now, what works for treating depression now may not work for treating the depression that people experience in 100 years. Right? Because there may be different cultural inputs and different cultural variables that moderate the experience of depression. Okay. So we're always going to be needing to continue to gather data and figure out new things that can help people. Okay, do therapists change what they do as new knowledge emerges? Yes, if they're good. They should, if they're ethical. If you fall far enough behind current knowledge, then you're guilty of malpractice and liable to lawsuits, ethics charges, all that sort of thing. That being said, this question does kind of bring up that there is and has been for quite some time a gap between research and practice, and both sides blame the other people. Right? So the clinicians say, "Oh, you researchers," or first the researchers say, "You clinicians, we do all this research and you don't use it. We found that what you're doing doesn't work. We found something doesn't work, and you didn't try this." And then the clinicians will say, "Well, I look at your research and it doesn't apply to what I'm doing. Right? You studied, this type of people, and none of my clients are like that. You studied this therapy and you found it to work, but there's no way I can do manualized therapy where I see clients every day for an hour a day for 2 weeks. I have no clients that have time to do that. It's not realistic." So you have this back and forth between the two groups, with some movement toward each other in the past 20 years. But there continues to be a gap. And the other thing, counselors and psychologists especially, ones who are trained in research, are a bit skeptical of new methods, of the latest research. So they're always listening, reading, talking about new things coming out. But when a new study comes and says, "Hey, here's a great way to treat depression," they don't go, "Oh, I have to learn that. I've got to stop everything I've ever done before and try this new thing." Because we've seen kind of fad treatments come out before where there'll be one study that comes out and suggests that something works, and then follow-up studies will kind of limit those original findings and say, "Well, it works for this group of people if done in this way, but it won't work for these people or if you do it this way." So psychologists have grown kind of wary of that and wait for an accumulation of evidence to come up. And then the way that they keep up with the new knowledge, some people read journals frequently. Most clinicians don't, at least based on my research. When I was undergrad, I did some research in this. They don't regularly read research articles. But the way they stay current is attending conferences. So you can go and people will be presenting the latest stuff, and you go to talks and you go to poster presentations and see kind of what's going on and what's new, and then figure out how to work it into your current knowledge base. Okay, so those were the major questions for the second set of postings. That's all for now. Take care.